You're listening to Who Said, a cardiology board review series. No fluff, just facts.
This episode is about vasculitis. We will go over large vessel vasculitis, medium vessel vasculitis, ANCA-associated small vessel vasculitis, immune complex associated small vessel vasculitis, and end with Kawasaki disease. What does all of this refer to? Large vessel vasculitis refers to Takayasu arteritis and giant cell arteritis. Medium vessel vasculitis refers to polyarteritis nodosa and Buerger's thromboangiitis obliterans. It is the small vessel vasculitides that consists of many different things. There are two kinds of small vessel vasculitis: ANCA-associated and immune complex associated. The ANCA-associated small vessel vasculitides are GPA, MPA, and EGPA. The immune complex associated small vessel vasculitides are IgA vasculitis, which is henoch-Schönlein purpura, cryoglobulinemic vasculitis, vasculitis of RA, SLE, or Sjögren's, cutaneous leukocytoclastic angiitis, and Behçet syndrome. Let's start with the large vessel vasculitides. Takayasu disease is a disease in young women, while giant cell arteritis is a disease in elderly men or women. Takayasu arteritis is 10 times more likely to affect women than men, whereas giant cell arteritis is 2 times more likely to affect women than men. Takayasu arteritis has a median age of onset of 25 years. In contrast, the median age of giant cell arteritis is 70 years old, and it is almost never seen under 50 years old. So even just going by these 2 points on epidemiology, you should already be able to reliably differentiate between these two presentations. However, there are many more differentiating features, which we'll go over shortly. Takayasu disease has no skin involvement. The same thing applies for giant cell arteritis, since these are both large vessel, not small vessel vasculitides. The small vessel and medium vessel vasculitides will all have peripheral neuropathy, skin, and GI involvement. So let's focus now on Takayasu's arteritis, which is arteritis of the aorta and the branches. Remember that Takayasu's arteritis can be stenosis or aneurysm of the aorta and its branches, most commonly the subclavian and innominate arteries. Therefore, it is much more common to have upper extremity claudication than lower extremity claudication. Actually, arterial stenoses occur 3 to 4 times more than arterial aneurysms in Takayasu arteritis. If arterial stenosis occurs at the renal artery, it causes hypertension. If arterial aneurysm occurs at the aortic root, it can lead to aortic regurgitation. In cases where Takayasu's arteritis involves the coronary arteries, it is almost always the ostia of the arteries leading to myocardial ischemia. Takayasu's arteritis of the aorta and its branches is notable for having unequal pulses or blood pressures and claudication in the upper extremities. Other than that, there is fever, arthralgia, bruise, and weight loss. Diagnosis of Takayasu's arteritis, which is often called pulseless disease due to the unequal blood pressures or pulses and claudication in the upper extremities, requires 3 out of the 6 of the following criteria: age of onset less than 40 years old, intermittent claudication, diminished brachial artery pulse, subclavian artery or aortic bruit, systolic blood pressure variation more than 10 millimeters of mercury between arms, and or angiographic CT or MR evidence of aorta or aortic branch vessel stenosis. Remember, you want 3 out of 6 of these criteria to diagnose Takayasu's arteritis of the aorta and its branches. Treatment for Takayasu's arteritis of the aorta and its branches is high-dose corticosteroids and a non-glucocorticoid agent such as azathioprine, mycophenolate mofetil, methotrexate, leflunomide, or IV cyclophosphamide. Elective revascularization of stenosed branch vessels should be delayed until acute inflammation has resolved. Now let's move on to giant cell arteritis of the temporal artery. Giant cell arteritis likes to affect the extracranial branches of the carotid artery, especially the temporal artery. The most common manifestations of giant cell arteritis are atypical headache in up to 90% of patients and tender temporal artery, which occurs in up to 70% of patients in someone who is over 50 years of age. Other than headache and tender temporal artery and scalp without a temporal artery pulse, there is also jaw claudication in half of patients, fever in a third of patients, fatigue, and if involvement of the ophthalmic artery, which occurs in 40% of patients, there will be optic neuritis, diplopia, and blindness. This is because, other than the temporal artery, giant cell arteritis may also affect the external carotids, ciliary, and ophthalmic arteritis. 50% of giant cell arteritis may have polymyalgia rheumatica, and 15% of polymyalgia rheumatica may have giant cell arteritis. So it is much more common for giant cell arteritis to have polymyalgia rheumatica than for polymyalgia rheumatica to have giant cell arteritis. Vascular histology of giant cell arteritis shows formation of granulomas, which are a collection of macrophages and giant cells. Giant cells are large multinucleated cells which are fused macrophages located near the internal elastic lamina of the vessel. There is disruption and fragmentation of the internal elastic lamina. The intima, or innermost layer of the vessel, becomes thickened, leading to narrowing of the vessel lumen. This contributes to reduced blood flow and ischemic symptoms such as headache and jaw claudication. Patients with giant cell arteritis often have normocytic anemia, reactive thrombocytosis, and mildly decreased albumin. In 1/3 of patients, liver enzymes can be elevated but usually revert to normal with therapy. A dramatic response to corticosteroid therapy should occur in 100% of patients within 72 hours, 24 to 72 hours of starting corticosteroids. Do not await biopsy or pathology results to begin steroids. You have at least 2 weeks to biopsy and still get a decent yield. You just need to start the steroids ASAP for giant cell arteritis. In giant cell arteritis, steroids are given at 40 to 60 milligrams per day for a month with a slow taper, and make it IV methylprednisone if the vision is threatened. There is so far insufficient data to recommend daily aspirin for the treatment of giant cell arteritis. If there's PMR, polymyalgia rheumatica only without giant cell arteritis, then the dose of steroids is 10 to 20 milligrams per day. But if there's giant cell arteritis, you need to give 40 to 60 milligrams per day of steroids a month. Methotrexate is an adjunctive therapy for giant cell arteritis and polymyalgia rheumatica patients who have relapses and are unable to taper glucocorticoids. Patients with giant cell arteritis receiving steroids should receive adjunctive calcium, vitamin D, and possibly bisphosphonates. Since giant cell arteritis primarily affects postmenopausal women and older men, steroids can predispose or worsen pre-existing osteoporosis, so they should undergo bone mineral density measurements. The ESR is a marker that does not always normalize with effective therapy and should not be relied upon as the primary indicator of ongoing disease activity in giant cell arteritis. Since giant cell arteritis patients can develop ascending aortic aneurysms, they should get yearly chest x-rays for up to 10 years to identify thoracic aortic aneurysms prior to rupture or dissection. There is no role for abdominal ultrasound because giant cell arteritis does not cause abdominal aortic aneurysm. There's also an entity called subcranial giant cell arteritis, a subtype of giant cell arteritis that does not affect the temporal artery and actually affects the great vessels of the chest is called subcranial GCA, subcranial giant cell arteritis. It causes upper extremity claudication and or aortitis, and the aortitis may lead to aortic root dilation, aortic regurgitation, and heart failure. That's why it's important, as in the world of cardiology, to be aware of this entity called subcranial giant cell arteritis. So as you are probably thinking at this point, having listened to the Takayasu section as well as the GCA section, that both Takayasu arteritis, which affects the aorta and its branches, as well as subcranial giant cell arteritis affects the aorta. But Takayasu arteritis is much rarer and occurs in 15 to 25-year-old women rather than elderly individuals. So just with the epidemiology alone, you should be able to distinguish these. Remember, Takayasu arteritis occurs in young 15 to 25-year-old women, not elderly individuals. Now, let's talk about the medium vessel vasculitides. The medium vessel vasculitides include polyarteritis nodosa, Buerger's thromboangiitis obliterans, and primary angiitis of the CNS. Let's start with polyarteritis nodosa. PAN, or polyarteritis nodosa, stands for pulmonary arteries not involved. That's how you can remember that, PAN. In addition, pulmonary arteries not involved is a disease that also has fever, peripheral neuropathy plus or minus foot drop with extremity pain, renal or visceral artery vasculitis leading to testicular pain, hematuria and proteinuria, hypertension, abdominal pain, and livedo reticularis. PAN also stands for pump ain't involved. Polyarteritis nodosa has no cardiac involvement in addition to no pulmonary artery involvement. However, I'm including this vasculitis because it's a pretty major vasculitis that exists, and you want to know about it when you're talking about vasculitides. In PAN, angiogram of the mesenteric or renal vessels will show microaneurysms and focal vessel narrowing. It also has unilateral orchitis and mesenteric aneurysms. 10% of patients with polyarteritis nodosa have HBV, hepatitis B virus. Polyarteritis nodosa has normal complement, and so do the ANCA-associated GPA, EGPA, MPA, as well as anti-GBM disease and IgA nephropathy. All of these have normal complement. You can biopsy the sural nerve, skin, mesentery, or kidney, and it will show vasculitis of medium vessel arteries with fibrinoid necrosis without granulomas. Recall that the medium vessel vasculitis and immune complex vasculitis and just MPA among the ANCA-associated are the entities that have no granulomas. Now let's move on to Buerger's thromboangiitis obliterans. Buerger's thromboangiitis obliterans cannot be diagnosed if someone has never smoked. 99.9% of the time, it is going to be somebody who has smoked. That's why this is relevant to cardiology. Thromboangiitis obliterans is a disease of smoking-related inflammation, corkscrewing, and thrombosis of the vessels of the upper and lower limbs, leading to reduced pulses and gangrenous ulcers. It does not involve internal organs. Thromboangiitis obliterans occurs in individuals under 45 years of age in Asia, 75% men, and presents with resting pain of the feet, calves, hands, or forearms. Angiography of thromboangiitis obliterans will show segmental occlusion of small and medium vessels, no evidence of atherosclerosis, and corkscrew collateral vessels bypassing the occlusions. Thromboangiitis obliterans cannot have positive RF or ANA. Whereas high-intensity statin therapy, regular exercise, and improved blood pressure or glucose controls have benefits for other cardiovascular conditions, they have not been shown to improve Buerger's thromboangiitis obliterans. Smoking cessation is the only proven reliable treatment for Buerger's thromboangiitis obliterans. The treatment for thromboangiitis obliterans, other than smoking is cessation, is iloprost. Patients who continue to smoke do continue to face a 45% risk of future amputation, so this is relevant to PAD. There is no role for vascular surgery because of the diffuse nature of the disease. Again, there's no evidence that statin therapy has any benefit in thromboangiitis obliterans. Now, let's move on to primary angiitis of the CNS. This is a vasculitis confined to the vasculature of the brain, spinal cord, and peripheral nerves. Although ESR is normal, there will be abnormal CSF with lymphocytic pleocytosis, which just means high white blood cells in the CSF, which is typically seen in aseptic meningitis. That's the idea of lymphocytic pleocytosis. You will also see elevated total protein in the CSF. In primary angiitis, the MRI, MRA, and CTA will be non-specific, but cerebral angiogram will show beading or alternating stenosis and dilation of the vessels consistent with vasculitis. Brain biopsy is falsely negative in 50% of primary angiitis of the CNS patients because of the patchy distribution, but when positive, it will show granulomatous vasculitis. Primary angiitis of the CNS is treated with cyclophosphamide for 3 to 6 months, then azathioprine or mycophenolate mofetil for maintenance. Now we can move on to the ANCA-associated small vessel vasculitis. What are the main characteristics of GPA, EGPA, and MPA? Let's start with GPA. Formerly known as Wegener's granulomatosis, this is a disease involving granulomatous inflammation affecting the upper and lower respiratory tract. There's glomerulonephritis, often pauciimmune, rapidly progressive, ENT involvement with chronic sinusitis, nasal ulcers, and saddle nose deformity, pulmonary involvement with nodules, cavitary lesions, and alveolar hemorrhage, and can have systemic vasculitis. Histopathology will show necrotizing granulomas with vasculitis, and this is more common in middle-aged adults. It is usually C-ANCA positive, which is PR3 ANCA positive. Now, eosinophilic granulomatosis with polyangiitis, or EGPA, which is formerly known as Churg-Strauss syndrome, is a disease that is associated with asthma and eosinophilia. You will have granulomatous inflammation with eosinophils affecting the respiratory tract. It has asthma and pulmonary infiltrates and can also have cardiac involvement in addition to pulmonary involvement with cardiomyopathy and pericarditis. It involves the peripheral nerves, causing a mononeuritis multiplex. Histopathology will show granulomatous inflammation with eosinophils and necrotizing vasculitis. It typically affects middle-aged adults with a history of asthma. EGPA is going to be P-ANCA positive in 40% of cases, although ANCA negative cases are also possible. P-ANCA is MPO-ANCA. Then microscopic polyangiitis, or MPA, is a disease involving non-granulomatous vasculitis of the small vessels. It has prominent renal involvement with pauciimmune glomerulonephritis. There's pulmonary involvement with diffuse alveolar hemorrhage, but no cavitations or nodules, unlike GPA. There's no upper respiratory tract involvement, distinguishing it from GPA. The systemic vasculitis aspects, it will involve the kidneys, lungs, and skin with palpulopurpura, but does not involve the heart. The way I remember the fact that it has no upper tract involvement is that GPA is the letter G kind of looks like like a mouth, when you see the upper respiratory tract from sideways, G involves the throat, whereas MPA does not have a G, so it does not involve the upper respiratory tract. That's just how I remember it. MPA is going to be commonly P-ANCA positive, which is MPO-ANCA positive. So to summarize those differences, granulomas are present in GPA and EGPA, but absent in MPA. Eosinophilia and asthma are hallmarks of EGPA, and for the ANCA associations, GPA is C-ANCA positive, MPA and EGPA are P-ANCA positive. The upper respiratory tract involvement will be seen in GPA and EGPA since they have the letter G in it, which looks like upper respiratory tract if you really stretch your imagination for me, and it's going to be absent in MPA. These differences can help you distinguish between the different types of ANCA-associated vasculitides and are important for the board exam. So a few other details. Churg-Strauss EGPA has a couple phases before the actual EGPA. There's a prodromal phase, which involves asthma, allergic rhinitis, and atopic dermatitis. An eosinophilic phase, which involves peripheral eosinophilia, lung eosinophilia with infiltrates, and a vasculitic phase involving polyangiitis up to 10 years later. GPA is treated with cyclophosphamide for induction, then methotrexate or azathioprine for 2 years for maintenance. If relapse, give rituximab. If RPGN, then you have to do plasma exchange. Without treatment, GPA leads to mortality in 1 year. With treatment, remission is usually achieved in 6 months. The treatment for MPA and EGPA is basically the same as the treatment for GPA. If there's no hemoptysis, anemia on CBC, or erythrocytes on bronchoalveolar lavage, then there is no diffuse alveolar hemorrhage. Now, that's the ANCA-associated small vessel vasculitides. We can then turn our attention to the immune complex-associated small vessel vasculitides. These include Henoch-Schönlein purpura and Behçet syndrome. Other than symmetrical palpable purpura of the buttocks, thighs, and legs, and hematuria and proteinuria, Henoch-Schönlein purpura also has arthralgia of the ankles and knees, colicky abdominal pain due to localized IgA vasculitis of the bowel wall, periumbilical tenderness, intussusception, and normal platelet count. Kidney involvement, which is an IgA nephropathy, is less common than other organs. Rarely, it can also cause pulmonary hemorrhage. Henoch-Schönlein purpura, remember, is an IgA vasculitis, which is the most common childhood vasculitis. It tends to occur after upper respiratory tract infections. We don't really see Henoch-Schönlein purpura in the cardiology world, but I included it here because it's such a major immune complex associated small vessel vasculitis in this overall discussion of the topic of vasculitis. You diagnose this by biopsying the most accessible affected organ, usually the skin, to find leukocytoclastic vasculitis with predominance of IgA deposits on immunofluorescence. Mesenteric angiography may demonstrate reduced blood flow and possibly irregularities in small vessels consistent with vasculitis, but it will not establish the specific diagnosis of IgA-mediated vasculitis. Serum IgA levels may be elevated, but are not sensitive or specific enough to be used for diagnosis of IgA vasculitis. Intussusception is the most common GI complication in Henoch-Schönlein purpura. And again, all of that is for HSP that occurs in 3 to 15-year-olds, not in adults, not in cardiology world. Now, in contrast, Behçet syndrome is something that you will need to know in cardiology. It is the cardiovascular manifestations in Behçet syndrome is diffuse aortitis, and this can lead to aortic root dilation and valvular insufficiency and heart failure. The cardinal characteristic of Behçet syndrome is having recurrent, meaning 3 times a year, oral ulcers and urogenital lesions, which refers to scrotal lesions in men and vulvar lesions in women. Other than this characteristic, Behçet syndrome also has pathergy, which is hyperreactivity to needle sticks. That's a key phrase on a question. Venous thrombosis, brainstem lesions or headache, diplopia, hypopyon, retinal vasculitis or anterior-posterior uveitis, inflammatory arthritis of the knees, GI ulceration indistinguishable from IBD, nausea or abdominal pain, glomerulonephritis, erythema nodosum, palpable purpura or acne. These are the features of Behçet syndrome other than recurrent oral ulcers and urogenital lesions. Remember that Behçet syndrome has pathergy, hyperreactivity to needle sticks, whereas sarcoidosis has anergy, A-N-E-R-G-Y, which is no response to intradermal injection of foreign antigen. Positive pathergy is when there is at least a 2 mm papule forming 24 to 48 hours after inserting a 20 to 25 gauge needle 5 mm into the skin. Scrotal and vulvar scarring may occur very rarely in conditions other than Behçet's disease, so it is quite specific for Behçet's disease. Bowel edema from inflammation or poor blood supply can occur in IgA vasculitis, infectious enterocolitis, IBD, and ischemic bowel disease. Now let's end with the miscellaneous vasculitides that don't fit in the above framework. The most important one to know in cardiology is Kawasaki's disease. 25% of untreated Kawasaki disease patients will develop coronary artery aneurysms. 4 to 8% of IVIG-treated Kawasaki disease patients will develop coronary artery aneurysms. In order to diagnose Kawasaki disease, you need at least 5 days of fever and at least 4 or 5 criteria: bilateral conjunctival injection, oral mucosal membrane changes, that's cracked lips or strawberry tongue, cervical lymphadenopathy of more than 1.5 centimeters, rash, and extremity changes, erythema of hands and feet or desquamation. If there are 3 or fewer of the 5 criteria, but you suspect Kawasaki disease, then check CRP and ESR and assess daily for new symptoms, since symptoms do not present simultaneously. What about CSVV? Cutaneous small vessel vasculitis is a skin-isolated leukocytoclastic vasculitis that can occur 7 to 10 days after initial drug exposure, such as from penicillin, cephalosporin, sulfonamides, phenytoin, NSAIDs, or allopurinol, or from infection, that's hepatitis B or C, or HIV, or unknown causes. If there is any visceral organ involvement, such as from the kidneys, lung, or heart, it is not CSVV. You want to consider MPA or GPA in that case. CSVV will have low serum complement levels and elevated ESR. You can do skin biopsy if you want, but the treatment is drug discontinuation and supportive care. Patients will improve within days of drug cessation. Both HSP, henoch-Schönlein purpura, and CSV, cutaneous small vessel vasculitis, are associated with leukocytoclastic vasculitis, but HSP is due to IgA, whereas CSVV is due to IgG or IgM. So this episode had a lot of other entities, disease entities that are important in rheumatology, and not so much in cardiology, but I did want to give you this overview of this so you have a lay of the land when you talk about vasculitis, since all of these vasculitis involve vessels, and vessels are part of the cardiovascular system. Thank you for listening.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.